In this video, we will define and describe stochastic effects of radiation. We will calculate and compare various life circumstances that decrease one's lifespan in order to ascertain our risk as radiation workers. We will then categorize cancer types that are caused by radiation exposure, including lung, liver, thyroid, breast, bone, and skin cancers. We will review the American Cancer Society's 2015 mammography recommendations for women of average risk for developing breast cancer. We will identify leukemia as a unique stochastic effect in dose and latency, and lastly, we will discuss cataracts and its associated dose thresholds. Now that we have covered the early effects of radiation exposure, let's look at the late effects of radiation. Late effects take place months to years after the exposure. Late effects are also referred to as stochastic effects, which is a statistical response to radiation exposure. Stochastic effects occur by chance and may occur without a threshold level of dose. The probability of suffering a stochastic effect is proportional to the dose received. However, the severity of the effects is independent of the dose. So in other words, an increased dose doesn't mean the exposed individual will experience a more aggressive cancer, but an increase in dose will increase that individual's chance of developing that cancer in the first place. Late effects include lifespan shortening, cataracts, cancer, as well as congenital defects. Those working with medical radiation need to be concerned about stochastic effects for ourselves and our patients. Some researchers would also claim there is a concern for our offspring. In this video, we will look at the stochastic or late effects that affect the individual exposed. In the next video, we will cover genetic effects and the effects of radiation on an unborn embryo or fetus. The first stochastic effect we will discuss is lifespan shortening. Early radiologists were studied and were noted to have a shorter life based on their occupation. A study in the 1930s revealed that radiologists lived 5 years less than other physicians. Keep in mind that this was before many of the radiation reduction and safety practices that are in use today. Today's radiologists do not show a significant difference in life expectancy when compared to other physicians. But what about technologists? There haven't been as many studies on technologists, but statistically speaking, working as a radiographer or other radiation worker shortens your lifespan by 12 days. It's a concerning figure. However, when I compare that same figure with other life-shortening statistics, working in medical imaging doesn't seem so bad. For example, did you know that by consistently increasing your speed from 55 to 65 miles per hour, you are statistically shortening your life by 40 days? And smoking a pack of cigarettes a day can shorten your life by 1,600 days. Somehow, being unmarried leads to you possibly living 2,000 less days, and being a guy can decrease your life by 2,800 days. Now, I kind of get that last one after watching various YouTube videos. So if you are a single dude, smoking a pack a day, speeding down the highway, your life expectancy is pretty grim. According to the stats, your life could be shortened by 17 years. So don't get hung up on the 12 days you may or may not lose as a result of your career choice. Radiobiologists estimate that for every rad we receive, we lose a day of life, and a typical radiographer accumulates 15 to 20 rads of occupational exposure over their lifetime. Through research performed on animals, the relationship of life shortening and dose is a linear, non-threshold dose response. The risk of developing stochastic effects from radiation exposure is a challenging thing to measure in and of itself. The risk is measured by comparing two populations, one that has not received radiation and one that has received radiation, and the percent of the stochastic effect is compared within those two populations. For example, if we wanted to find out the risk of turning into a raging green giant, we would look at the percent of the exposed population that this fictional stochastic effect is being demonstrated and compare it to the unexposed population showing the same stochastic effect. This is termed the relative risk. When the relative risk is 1, there is no increased risk. If the relative risk is 1.5, that means the risk is 50% greater in the irradiated population. The relative risk helps us to put stochastic effects into perspective. It's easy to freak out about radiation when we see a statistic that 25% of the irradiated population is turning into raging green giants. But that becomes far less scary when you learn that 24.9% of the non-irradiated population is also turning into raging green giants, because that's hardly scary. A more encouraging concept is the theory of radiation hormesis, is the belief that low levels of radiation are beneficial and may provide a protective effect on cells by stimulating molecular repair. This school of thought is based on looking at relative risk for populations like Denver, where the stochastic effect should be greater because of the increased radiation received by living at a higher elevation and the presence of radon in that region. However, studies have shown that the relative risk is lower than the general population, but it has not been proven, and you should know that hormesis does not supersede ALARA. As you will see, radiation effects are not a joke. You may be surprised to know that 33% of the general population will get some form of cancer in their lifetime. As a radiation worker, for every 10 rads we receive, our chance of acquiring cancer in our lifetime increases by 1%. To put this into perspective, if I were to work for 40 years in imaging and during that time I received 20 rads of exposure, my chance of getting cancer increases from 33% to 35%. Bear in mind that this statistic is having a diagnosis of cancer, not dying from cancer. That statistic is even smaller. Next, I want to briefly review the types of cancer that have been associated with radiation exposure. The first we will look at is lung cancer. It was noticed that early radiologists had an increased incidence of lung cancer, although this is not seen today. In other populations, the incidence of lung cancer has been linked to radiation exposure. Bohemian pitchblende miners had nearly twice the incidence of lung cancer, and it was originally attributed to the dusty mine environment. However, it was later discovered that radon in the mines was the true culprit. Similarly, uranium miners also had an increased incidence of lung cancer from breathing in radon, a decay product of uranium. As these groups of miners breathed in the radioactive gas, it was deposited in their lungs where it underwent additional decays depositing low linear energy transfer or LET and high relative biological effectiveness or RBE alpha particles. These alpha particles gave high doses of a concentrated damage to the miner's lungs, resulting in this population having 8 times the risk for developing lung cancer. Medical imaging was responsible for a number of liver cancer cases in the 20th century due to the administration of a contrast agent called thorotrast. This contrast was used in angiography studies and contained the radioactive isotope thorium, which gave off large amounts of alpha particle radiation that was concentrated in the liver and spleen. Thorotrast was discontinued in 1945, but the latent period for the liver cancer was approximately 15 to 20 years after exposure. Thyroid cancer is another type of cancer that the medical field inadvertently caused in a specific population. In the 1940s and 50s, newborns were treated with radiation to reduce thymus gland enlargement. The treatment led to a higher incidence of thyroid cancer in this group after a 20-year latency period. Additionally, overactive thyroids were once treated with radioactive iodine-131, but this practice stopped after an increase in thyroid cancer was noted within this population. Controversy has surrounded the incidence of breast cancer and radiation for some time and continues today. Back in the 1960s, it was discovered that radiation was able to induce breast cancer when tuberculosis patients underwent fluoroscopic procedures pre-image intensification. Persons undergoing these high radiation exposures to their chest region were 10 times more likely to develop breast cancer. However, it was found that one group of individuals that underwent the same treatment and high doses of radiation did not have nearly the incidence of breast cancer. It was discovered that this specific group of patients was placed so the radiation entered the posterior aspect of the patient, significantly reducing the radiation dose to the breast tissue. Around the same time, the medical community was noticing a correlation between the TB patients and breast cancer. Some began to question the necessity of mammography due to the increase in breast cancers. Back then, mammography doses were significantly higher than today's, resulting in an increase in breast cancer. In October of 2015, the American Cancer Society yet again changed its recommendations about the use of mammography for women of average risk to develop breast cancer. Women between 40 and 44 can decide for themselves if they feel that a yearly mammogram is necessary. Women between 45 and 54 should receive an annual mammogram, while women 55 and older have the choice to continue with yearly mammograms or opt to only have mammography performed every other year. Another suggestion is to only continue with mammography as long as the woman is in good health and expected to live 10 or more years. The guidelines for those at high risk for breast cancer have separate recommendations and are recommended to start yearly mammography at 30 years of age. In addition, these women should also receive MR imaging of their breasts. In countries outside the United States, mammography is not used as often due to concerns of radiation-induced breast cancer. Bone cancer is another type that is associated with radiation exposure. This was overwhelmingly seen in an unfortunate group of watch dial painters in the early 1900s. To create a fine point of their paint brushes, the workers would place the bristles between their lips, and because they painted with radium sulfate, a small amount would be ingested. This amount added up over time, and the workers, which were mostly women, started to become ill. The radium would deposit in their bones, giving off massive amounts of internal alpha radiation, and later large bone tumors would form. Skin cancer was another common diagnosis for early pioneers in radiology. Hands and forearms that were in the direct beam of radiation often resulted in radiodermatitis that in some cases led to cancerous skin lesions. The latency period for skin cancer is 5 to 10 years. Skin cancer incidence demonstrates a nonlinear threshold dose response. Another type of cancer to discuss is leukemia. Leukemia requires the least amount of dose to manifest. You may have already come to the conclusion that this is because the bone marrow is sensitive to radiation, and that would be correct. Red blood cells are formed in the bone marrow, and irradiation of the bone marrow decreases the number of red blood cells. You may also recall that lymphocytes are also extremely radiosensitive. Leukocytes, or white blood cells, will continue to proliferate and take over, causing the dangerous and sometimes deadly leukemia. High doses to the bone marrow can result in leukemia being seen as early as 4 to 7 years after the exposure, but can manifest in individuals as long as 20 years later. Leukemia was seen in early radiologists with their high exposures. You should know that leukemia follows a linear, non-threshold dose-response pattern, and patients receiving radiation treatments and high radiation dose procedures are at risk for developing leukemia later in life. The last stochastic effect that I want to review in this video is cataracts. Cataracts cloud the eye's lens and impair vision in that eye. In some cases, it can lead to blindness if not treated. Cataracts were first associated with radiation exposure when high-energy nuclear physicists developed cataracts prematurely. Studies have shown that cataracts begin to manifest after an exposure of 200 rads of acute dose to the lens of the eye. However, a fractionated dose, or one that is spread over time, will begin to result in cataracts after a dose threshold of 1,000 rads is reached. The average latent period for cataracts to manifest is typically 15 years. However, it has been observed that this time decreases as the exposed individual's age increases at the time of exposure. For example, a 20-year-old exposed with 400 rads might develop cataracts 16 years after exposure, while a 70-year-old exposed with the same dose may develop cataracts after only a 9-year latency period. In the next video, we will discuss latent effects as related to genetic effects and the long-term effects of being irradiated in utero.